Hello and welcome to Pain in the Podcast. My name is Dr. Joseph Parsons and I'm joined by the wonderful Dr. Joshua Craw and Don Wigesoria. Today we're going to be talking about pain in the LGBT community. Welcome in. Hello and welcome to Pain in the Podcast. Today we are going to be talking about the LGBT community and pain, but before we get into that, we are going to give a fact about each of us. So let's start this week with Josh.
Yeah, so here's a fact about me that I don't think anybody else knows, but at about the age of 12, for approximately 4 months, I was an avid collector of plastic bags.
Did you seek out special looking plastic bags, or were you happy just getting any grocery bags?
I was buying one on eBay.
You were buying them.
You're joking?
No.
Are we saying like did they all have to be different bags? It wasn't just like any plastic bag?
No, it's interesting ones, because you sometimes get a bit of interesting sort of
At
like
what age
design.
did you say you were?
About 12.
How did you have the money to buy these bags?
I mean, they're not
Pocket
expensive,
money.
are they? They're plastic bags.
It was literally like 10 pence on
And
eBay.
plastic bags were free then.
When they delivered them, were they delivered in another bag?
Josh was like, yes! Yes!
Double bags, small bags, yes! Give me all your bags. No, I mean, it's just very cheap delivery. So, I mean, like, you spend maybe like £1 in total, including delivery.
Okay.
I'm pretty certain that like 90% of the listeners listening to this will have a bag of bags at home, and 12-year-old Josh would have just been like rubbing his thighs, like, oh, I'm going to take that bag.
Oh, so many bags.
Josh goes around to people's houses when he was 12, like family friends, and is like, have you got a plastic bag I can borrow? And then just like grabs the whole bag of bags.
Did you just interrupt shoppers in the supermarket and say, "Oh, that's a really nice bag you've got. Can I take it?"
Unfortunately, no.
Oh.
That'd have been a cheaper way to get bags, but then
Yeah.
I feel like that's
Not
amounts
a
to
thief.
robbery.
You know, I had an idea when I don't know how old I was, very young, where I was very eco-conscious at the time.
Okay.
I still am. No, but I thought it would be a good idea to go around the neighborhood collecting most of the bags that people just stuff in their random junk drawers and other bags.
Okay.
And then take them to the supermarket and have like a little stand full of bags that anyone can take, because it stops them from buying new bags.
That's a really good idea.
Right?
Did it work?
I never did it.
How
Did
old
you
was
start the process?
No.
Okay.
I
How
just
old
thought
was
of
he?
it. How old was I?
Yeah.
Around 13, 14.
Oh, see, the obsession with the bags, it comes between the ages of 12 and 13.
Yeah.
Well, no. That's really interesting. That would have been a good idea.
Yeah, maybe we should do that. No,
Maybe.
I
don't
don't,
think
have
that's
the
gonna
time to
happen.
do that.
If I'm going to be honest.
No.
Yeah.
Full-time doctor goes around collecting bags,
In his
saving
spare
people
time.
5 pence a bag.
It's 30p now for a bag in some supermarkets.
Good, it should be more.
What?
Josh just nearly choked on his Pepsi. Don, do you want to give us your fact this week?
Yes, so my fact is that I might be in the minority of people who like to eat the core of a pineapple. I really like the core of a pineapple. I like to chew on it. It's really fibrous. If
Do you
that's the right
actually
word.
do you chew on it like some people chew on cartilage and then they don't eat the cartilage? I like
No,
to
no,
eat the
no,
cartilage
no,
in
no,
meat,
no,
but
no.
you actually eat it all.
Yeah. Sometimes some if it's like a really bad pineapple, you just can't chew it, as in it just won't break down,
yeah.
and so you just end up spitting it out. Disgusting. But no, most pineapples are fairly nice, and yeah, it's a different taste, it's a different flavor, it's a different level of sweetness.
What?
And I
not
just-
sweet.
No.
And gritty.
Have you never had the core of a pineapple?
I've
before?
accidentally had bits where I haven't been. I've been too stingy with my cutting. Tried to be cheap and then ended up getting some of the core and thought it's not good.
What does it taste like then? Does it just taste like pineapple but slightly less sweet? Or
Yeah, it's just more. It's just slightly less sweet.
Okay.
It's like the gristle of pineapple.
It's like if you were to infuse a piece of cardboard with pineapple juice.
You can do that, you know.
Yeah, but then this is natural and part of the fruit.
Oh, God.
Well, I guess, you know what? Waste not, want not.
Yeah.
I'm not sold.
I wasn't trying to sell. I just said I was in the minority of people who
You
like
definitely
it.
are in the minority in that respect. Like, that is
Niche.
very niche.
Joe, what about you? What's your fact?
My fact is that I didn't learn to ride a bike until I was 11 years old.
Loser. No, that's... What was it like learning a bike at that age?
Learning a bike.
Learning a bike at 11 years old. Learning how to ride a bike at 11 was odd. Everyone else could do it. Everyone would go and like play out with their friends. They'd go ride around on bikes. And I just basically never got round to it. And the thing that inspired me, quite depressingly, we had like a thing in my primary school in year 6. So for any international listeners, you're 10 or 11 years old. And they had this thing that was like celebrating triathlon for some reason, because like what else would a fucking primary school do? I don't know why they were thinking about triathlon in particular, but we had to go running, swimming and cycling, and so we would like go to the swimming baths. We all swam, and I was a terrible swimmer, so that wasn't great. It was a bad start. And then we had to do a run, which was great, and we had to cycle 2 laps of the field, and I couldn't ride a bike, so I just sat on the side and cried.
Oh, I'm sorry, Joe.
And then that peer pressured me to ride a bike. But I think it's quite fun
What
now.
a strange way to learn how to ride a bike.
Yeah,
But-
learn how to bike.
Here
Through
you are.
humiliation.
Yeah, but now I quite enjoy it. I don't ride a bike very often at all. I probably haven't ridden one for about 5 years. But last time I rode it, I enjoyed it, and I'm sure I will enjoy it again.
And what do they say? Once you learn, you never forget, eh?
Exactly, and I didn't forget last time. That was another few years since I'd ridden a bike last time. So
Good.
I used to like go downstairs and stuff on my bike when I was about 7.
But were you
8
still sat
-ish.
on it, or were you just falling downstairs on the bike?
No, I was. Well, I thought I looked cool.
You were controlled.
I was
you were still on at the
controlled.
bottom.
Yeah.
Okay.
I was on the bike. Yeah.
My mum, when she was 3 years old, rode her tricycle down the stairs, and
Accidentally.
no, on purpose, fully on purpose, because she wanted to know what would happen.
She died.
No, she's fine. Well, I'm here, so. But my granny always said afterwards that she was like a troublemaker, even though my mum is like not a troublemaker at all. She's lovely, a wonderful person, and very
Yeah, your mum does not strike me as a troublemaker.
as a reprobate. But no, she rode her tricycle down the stairs, and my mum points out that my granny really should have done something about this when she heard the sound of dum, 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 as my mum was pulling the tricycle up the stairs, and it's just like, surely you would notice that sound.
Was it one of those? So I had like a little plastic wheeled tricycle, as in the wheels were made out of plastic.
This
or
was in
it?
the early 1960s.
So probably wood.
Metal.
No, wood. No, metal. I assume it would have
alright.
been like a small metal tricycle,
Okay.
so it would have been quite dangerous if she got caught up in
Yeah.
it. I don't think she was badly hurt. I think she was just a bit shaken, obviously, because other than Don, no one else was riding bikes down the stairs in their childhood.
No, but what a way to experiment for your mum.
Yeah, well, exactly.
She is like such a sweet woman. I would never have. I don't understand why your grandma would have said that.
She's got her mischievous side.
Yeah.
She's got a hint of the rapscallion.
Like you.
Yes, indeed. Josh, what have you learned about yourself this week?
So my learning this week is, as this episode's being filmed in an undisclosed location in London, is that even if you're not in central London, the cost of meals and eating out is horrific.
Yeah.
I got a mixed grill last night, and it cost me £38. And it was 2 sausages, a small piece of steak, a little bit of salad, and what they said was half a confit chicken. I can confirm that it was at least maybe the size of a quarter of a chicken.
It was definitely not half.
It was a tiny chicken, that was the
Yeah.
problem.
And it was overcooked. The breast was very dry.
Ugh.
Definitely not confit.
No. Okay, Don, what have you learned about yourself this week?
I've learned that I might live 10 years longer because I play a racket sport, and a study has shown that people who play racket sports are able to live longer due to the cognitive benefits. Don't ask me for any references because I can't find them anymore, but I did read that somewhere. And there you
BuzzFeed.
go. It was not BuzzFeed.
That's really interesting.
Yeah.
Yeah,
So the cognitive more than the physical.
I think so.
That is genuinely interesting. I think that's something that we might be able to cover in the breakdown, in fact.
I think it is.
Yeah.
My auntie Jill, who is currently 94 years old at the time of recording, she played tennis until her late 80s. And my favourite memory of my auntie Jill was that we went for my granny's 80th birthday party. So Jill would have been mid-80s by this point. and my brother we were kind of leaving the meal, and Jill, being still fit and healthy, ran out in front of everyone else, got into her car and waited for my brother to walk in front of her car, and then she accelerated and slammed the brake on, so she nearly hit him, leaned her head out the window and said, "Got you, fatso!" and then drove off. Which I like to think that kind of hint of mischief will still be with me when I'm in my mid-80s.
Hint of rapscallion.
It runs in the family then, eh?
Other side of the family, so God knows I didn't have a chance.
Yeah.
There we go. And this week I learned about myself that, and Don will be glad of this, that I am bird repellent.
Ooh.
Yes, this is why we're friends.
I just follow him around. No, I had been having a handful of birds appear in the garden at my house, and I quite like bird watching. I wouldn't go out and do it, but I do like when birds appear. I am a big fan of just seeing birds. I wouldn't sit for like 6 hours to find a specific bird. I'm just like, bird. And it could be a pigeon, it could be a sparrow, a blue tit, whatever. It's all exciting. And I put a bird feeder in my garden to encourage the birds.
How dare you?
And I haven't seen a single bird.
This feels like a betrayal.
Well, don't worry.
Sorry, I was too enraged. I didn't actually hear what you said.
I said, I put a bird feeder in my garden and I haven't seen a bird since. So I don't know. I promise it's bird food.
It's because they're ungrateful little shits.
What food did you put in?
It was just nuts.
Well,
Mixed
put out
nuts.
some...
It was bird feed. Like, it was like nuts and seeds.
I think you should, to improve on that, I think you should just take your bin out and just dump it on the bird feeder, and they would definitely come.
Pigeons would.
Pigeons
None of the other birds that I'm trying to aim for would come.
No.
So there you go. I'm bird repellent, so I'll follow Don around to make sure none of them get to him.
All right, so this episode is going to be about the LGBTQIA plus community and their experience of chronic pain. We would like to put out a bit of a disclaimer. Whilst we the three of us definitely don't represent the entirety of the queer community, we have tried our best to find as much research and as much reliable research as we can, but it has been difficult to find studies on particular subgroups within the queer community. So we'll refrain from sharing any opinions or any theories about that.
And so we're sorry for anyone who is listening today who is either non-binary, intersex, asexual, or anything, to be honest, beyond L, G, B and T, because they have been really underrepresented in the research. And hopefully that is something that will change, and hopefully this episode might bring a little bit of light to that and encourage people out there to start thinking a little bit more about how we can be more representative of minority groups. But in the time being, there is a lack of research, so apologies if you feel like you haven't been represented in this episode.
Yeah, we do understand the irony of that. We are part of the problem.
But we can't afford to do the research. If someone would like to give us a cool £1.5 million programme grant that we can spend the next 4 years doing research into sexuality and gender in pain, Lord knows. Well, I was going to say we'll quit our jobs. I'll quit my job. I don't know if you guys will. Don will come with me.
I will definitely.
Don come with
I'll
me. Josh
come
might.
with you.
We'll see.
Okay. I don't think this is a problem we're going to face, to be honest. I think it's worth starting out today's episode if you guys are happy with a discussion about our own positions sort of within or allied to the LGBT community.
Yeah, so for myself, I identify as gay, and so, yeah, there you go. That's my two pence.
I make up the B in the LGBT, which I like bacon as well, so, it's pretty good.
Josh would rearrange LGBT to G, BLT.
Exactly.
And I myself am an ally. I am a heterosexual white man, so I'm probably kind of the least representative of any minority, but nonetheless, I hope that I can be a decent ally to the community. But I like that we represent Team GB.
Yes.
Team gay boys.
You are one of the most alliest allies that I've ever met, so, yeah.
I do really appreciate that. But should we start off then? So I think it was important for us to mention that because we've spoken in the past about making sure that we have guests who are representing communities within episodes, and we don't want you to think that we are three cis heterosexual men just chatting about things that they have kind of no insight into. That's only one of us who's chatting about things that they have no insight into.
And here's the one that's talking the most, so read into that as you will.
Honestly, I
Oh,
think you
God.
know more about it than I do at this point.
I've tried to do as much research as possible to make up for my lack of lived experience, and I really hope I don't make a tit of myself. Shall we start talking about how prevalent pain is in the LGBT community?
Yeah, absolutely. There was a study in the US, which was the Growing Up Today study. That was a longitudinal study of over 8,000 young women, and 44.3% had chronic pelvic pain at some point. The relative risk compared to heterosexual women was 1.23 in lesbian women and 1.3 in bisexual women. That means that compared to heterosexual women, if you're a lesbian, you got a 23% increased risk of having chronic pelvic pain, and if you're a bisexual woman, you've got a 30% increased risk of chronic pelvic pain.
And so that's specifically looking at pelvic pain, but when you think about kind of pain more generally, there was a study looking at gender and sexual minorities that they call in here, so anyone who doesn't represent cisgender or heterosexual, basically. And they found across nearly 5,400 participants, 54.6% of them had chronic pain. And so if we're going with the FIAS study, the one we've quoted before, that 43.5% of adults have chronic pain in the UK, that's over 10% higher incidence of chronic pain among gender and sexual minority communities. In that particular study, the cisgender population they used, the pain in cisgender women was 1.5 times more common than in cisgender men, which is something that we know in the literature. Pain does seem to be more common, chronic pain at least, in female populations. And then it was twofold higher than the cisgender populations in transgender and non-binary individuals. So it seems like there is something in this, and we'll get into a little bit more why this might be later on, but there is a lot more prevalence of pain in these communities.
There was another study of 56,000 transgender people specifically, and it found that pain in transgender women who are not on hormone therapy was 80% more than cis women, and those who were on hormone therapy was 82% more than cis women. Pain in transgender men not on hormone therapy was 66% more than cis men, and those on hormone therapy was nearly double compared to cis men.
Now, that's quite remarkable, actually, isn't it? I mean, that shows a very clear sort of trans compared to cis, there is a higher incidence of pain.
And like we said before, we'll get onto this a bit more, but there's elements of stigma involved in that and kind of mental health elements which will contribute towards a more negative pain experience in individuals who do start developing pain. But there's also this idea that people in the LGBT community often are quite disengaged from the healthcare system because of negative experiences they've had. But we'll dive more into that in a little bit. But one last thing I wanted to quickly mention in terms of prevalence of pain, there was a study of 1.15 million veterans, so military veterans in the US, and they looked at LGBT individuals in that community versus non-LGBT individuals. And they found that people in the LGBT community had higher likelihood of having a musculoskeletal disorder, higher likelihood of having a mental illness, and higher rates of substance use disorder. So again, clearly there's something going on here in the experience of LGBT people that is leading to them having higher prevalence of pain and mental health issues.
So, I mean, over 1.1 million participants in a study, that's absolutely phenomenal data, isn't it?
Pretty unheard of, to be honest.
Yeah, I wonder as well, with it being military veterans, do you think that sort of may have skewed sort of the data?
In what way?
I'm just thinking, military veterans as a whole have higher risks of, well, particularly after service, high risk of substance misuse, high risk of chronic pain, thinking injuries, that sort of thing.
And PTSD relationship with pain as well.
Yeah, and was this an American study, did you say?
It was, yeah.
Because I think, are the Americans still on a don't ask, don't tell policy? Or are they
I don't know
now
what
more
that is.
Oh, yeah. So basically, pre-2000s, you couldn't join the military if you was gay.
Oh, sorry. Okay, yes. No, I have
Yeah.
heard about this.
So then after that, obviously that's incredibly discriminatory. They opted for a policy of don't ask, don't tell. So
Don't ask people if they're part of the LGBT community, and if
Exactly.
you are, don't tell people that you are.
yeah, so just brushing it under the closet.
Under the closet.
Yeah, no, I picked my words right.
Okay.
It's a heavy closet sometimes.
Yeah, especially with 1.15 million.
Yeah.
Yeah.
So, should we dive a little bit into the discrimination that LGBT people face in terms of pain and its management?
Yeah, absolutely. I was wondering if that potentially is the effects of that don't ask, don't tell. Because I know when I was still in the closet, I was feeling stress about that. When I was in an environment where it absolutely wasn't acceptable to be gay, to be bisexual, to express your true feelings, I did feel a bit of pressure about, oh my God, what if I say the wrong thing? What if I accidentally out myself? That sort of thing.
Yeah.
And I'm just curious. Obviously, we're not making theories here, as we said, but I'm just wondering what it is that leads these military veterans to higher incidents.
Because you're right, it's a reasonable guess that people not being able to express who they are would be a stressor that may not cause pain, but can at least contribute to a negative environment that would make pain more likely.
Yeah, and anybody that's interested in following up on this, I think we'll be talking about this in the breakdown too.
We most certainly will, which you can see on our Patreon. So should we think about then talking about the discrimination that LGBT people face in pain management?
Yes, so we found that in a study of 47,000 children across the US, those who experienced discrimination due to sexual orientation or gender identity were 3 times more likely to develop chronic pain than those who had not experienced any discrimination.
Wow. So it shows just like
3 times, that's a lot.
that's a hell of a lot. And to have kids at that age as well, where people, maybe they're kind of vulnerable, maybe they're scared about expressing who they are, things like this really don't fill you with kind of... You'd like to think we could say to children now, don't worry, it's fine to be who you are, you can express yourself. But clearly, like, there's still a huge issue with discrimination going on. And like you say, that threefold is a massive increased risk of pain.
Mm-hmm.
And that is a direct result from discrimination. I'm assuming that this study that you've looked at, Joe, took into account other external factors as well.
Yeah, and it looked at covariates as well, so things like sort of socioeconomic background, for example.
Yeah, absolutely.
And it's not just kids that kind of face these issues. Like LGBT adults face higher rates of violent victimization, medical mistreatment, and have higher levels of social isolation. So you've got this kind of being subject to violence, being poorly managed by the medical community, and then feeling like you're excluded from society more generally. Like, these are all big contributors to what causes people to have pain. And we already said before in our episode about depression, like, social isolation is a big contributor. So that combined with poor healthcare.
Yeah, I mean, I know people that, not just social isolation from the friends or what have you, but I've known people that have come out of the closet and then been isolated from their family.
Yeah.
Particularly in people that come from communities and countries where it is still a taboo topic.
Yeah, and those are usually the adults who have higher rates of depression, of anxiety, suicidal thoughts and behaviours when compared to cisgender individuals.
And so, like, and it's understandable why you'd have those higher rates, isn't it? Like, if you've been kicked out by your family or you've been isolated from your friends, from your community, like, of course it's understandable that these kind of mental health issues are going to start cropping up.
Yeah, and obviously we're not saying that everybody that's part of the LGBT community has those issues. Like,
Yeah, they might not have faced the same challenges.
exactly.
Yeah.
Or they've found a way to cope with it or to move past it. But obviously it's a really challenging thing to cope
It's
with.
a unique experience for everyone.
Yeah.
It is.
But I think it's worth us thinking as well, like, about barriers to care that these individuals face. So we kind of spoke about active discrimination that people have faced, but what are the barriers that people in the LGBT community face, like maybe those more subtle forms of discrimination that make it challenging for them to engage with healthcare?
Yeah, so I think the recent literature of LGBT plus individuals does show that there are higher rates of poverty, discrimination by healthcare providers, and actually 33% of transgender people in one study said that they'd been refused treatment, or even received incompetent care, or had been harassed during their care interactions. Just, it's so abhorrent, isn't it? I mean, you go to somewhere, you're going to a health professional. You're not going there for the fun of it. You're going there because you need help. Yeah. And then you're experiencing this. I mean, if that was me, if every time I'd gone to get help from a GP, from a doctor, from a nurse, anything like that, and I'd been discriminated like this or been harassed, in fact,
yeah,
I think it's gonna make me not want to represent. It's gonna make me want to not use those services.
Yeah, and a lot of people going into these appointments have already heard such stories before, and so they go into it with that kind of a cautious mindset.
Yeah.
They're already treading on eggshells, and then they go in, and this happens. It's just everything's been confirmed. Yeah.
So I remember when I was, how old was I? I must have been 17, and I went in to see a GP. It was out of hours. A very old school GP. He was an elderly GP, probably approaching retirement. And I remember that I wasn't feeling too good, so I was going about my mental health actually at the time. I mentioned that I'd broken up with my partner, and he was like, what's her name? Why did you guys break up then? And I was like, well, he. And he was, no, surely you mean she? I was like,
you're joking.
I mean, like, no, actually I don't, because, I'm dating a man. I was dating a man. And it's just like, and his face completely changed, and it's just like, I felt quite uncomfortable in that situation then.
And that's the thing, is like you'd like to imagine that healthcare providers who have gone into a profession to care for people wouldn't be like this. But Josh and I he was reading an article, was it BMJ? No, BMA, British Medical Association.
Yep.
And he was talking about this person who this isn't towards the LGBT community, but had been using racial slurs in the workplace, a surgeon, and had been called out for it lots and lots of times, and had been quite chauvinistic in his behaviour as well. Was taken in front of the trust chief executives, fervently denied that he'd said any of this stuff. This journalist that wrote the article called him up and was like, what do you say about these allegations? And then he was, oh no, it's all bullshit, rah, 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 rah. And then when he thought he'd put the phone down, he then made a slur against the reporter. And so she wrote the article and was like, though he denies all of the allegations, the writer of this particular report heard him say, and then quotes it, when he thought he'd put the phone down. And I was just like, it was quite funny that he'd put his foot in it so much, because at least people like that now are going to see repercussions for their actions. But it does show you, like, I'm not going to say a lot of healthcare professionals, but there are people out there who are harbouring really negative attitudes. In fact, there's a study of medical students that showed that nearly half of them had negative attitudes towards lesbian and gay people. And so we all know the impact of attitudes, and kind of, even if it's unconscious biases, going into these care interactions with these negative attitudes, no matter how equitable you think you are in your care, it's going to negatively impact the treatment that people receive.
I mean, I wouldn't take that too negatively, saying that all doctors, all medical students, because I remember being in a lecture when I was in medical school, and one of the consultants who was doing the lecture said, I had a medical student come to me the other week, and he asked me, what do we do if we feel uncomfortable about treating lesbian, gay, bisexual, trans people? And the consultant's response was, you find another career.
That's a good consultant.
Yeah, that is what we like to hear.
What do we do if we feel uncomfortable treating humans? No.
Yeah, become a vet.
Find some aliens.
Yeah, but I guess maybe that's a good thing to lead us into talking about how individuals in the LGBT community can be managed well in healthcare. Like, what can we do to support them?
There's a study that showed that young people experiencing gender dysphoria scored highly on pain burden, so the feeling of, experiencing pain, and functional disability and pain catastrophizing.
But then for those individuals, there's the Endocrine Society Clinical Practice Guidelines, which are basically like a protocol for helping to manage people with gender dysphoria. And obviously everyone's experience is different, but it makes sure that they get support from mental health practitioners to support with the emotional challenges of dysphoria. And also it gives them support with their hormonal treatments as well. So as well as looking at their pain and kind of disability as well, there's this guideline to ensure that people don't slip through the cracks and receive poor care. There's kind of a minimum standard of care for these individuals.
That seems like a very holistic approach.
Yeah, I think so.
And the way that we manage those guidelines and the way that we can ensure that they're enacted is actually what I believe is through medical training, medical teaching, starting at an early stage within the careers of doctors, so starting at medical school.
Yeah.
Making sure that we've got specific sessions put aside to make sure that we cover LGBT plus health, because biology is the same.
Yeah.
Somebody's heart works the same, whether you're gay, trans, bisexual, lesbian, non-binary, whatever you want, whatever you are. Like, it doesn't make a difference. But how we treat people is the difference.
Yeah. And in the States, in Canada, there's less than 5 hours of medical education relating to LGBT health. So that's not LGBT and pain, that's anything relating to LGBT. There's less than 5 hours of training. And, you know, like we complain about there being less than 20 hours of training on pain. Is this just feel... I know obviously you can't train medical professionals in everything to the standard that you'd like them to. They do have to learn on the job to an extent, but it does feel like we're under-training staff in this respect.
Yeah, it does seem like there is a lack of training and education, but I do hope that these curriculums still demonstrate how the students can learn on the job and gain that experience. So, Josh, can you tell us a bit more about your experience when it comes to that?
In terms of medical school or in terms of training post-graduation, or what would you like to know, Don?
We could go with both.
Perfect, yeah.
Start with the medical school.
Medical school. We had an absolutely lovely lecturer. I'm not going to name her on here and dox her, but she covered a lot of the, I'd say, non-scientific aspects of the curriculum. So particularly the social side of things, how we act as doctors, how that impacts patients from a sociological point of view. And so we did have quite a few lectures on that, actually. I'd say over the first 3 years of medical school, maybe 4 lectures a year on that.
Okay.
So actually, compared to from the figures that you cited, that's quite a lot. And then what we sort of saw from that point of view would be from an endocrinology point of view. So endocrinology is a study of hormones and how they act in the body and how we can manage those levels of hormones, and how, if we have inappropriate levels of certain hormones, how they act. So we looked at all of the hormones. We looked at actually people that are transitioning as well, for example, how we can look at the hormone profiles and how we need to treat those patients. I mean, it's an incredibly specialised field. It's not something any junior doctor is realistically going to be tasked to do. And when I say junior doctor, I mean those in foundation training, so within a couple of years after finishing medical school. But there's definitely a lot more room to improve. I think my medical school in particular, St George's, was quite good with that sort of thing, as opposed to, okay, here are the biological facts that we need to follow. Bish, bash, bosh. We did cover a lot more of the communication skills, a lot more of how we treat patients holistically in the biopsychosocial model.
Yeah. I'm interested, though, like within that kind of interaction with individuals in the LGBT community and the training you received, there's one article that talks about how you can effectively support people in the LGBT plus community with pain. And they said, ask about any terminologies you're unsure of. Like, don't be embarrassed to ask questions. Just be upfront and honest about what you do and don't know. I'm interested, like, for you guys as part of that community, what would you want people to, like, would you be happy for clinicians to ask you? So I know, like, Don, you're very positive around the term queer.
Yes.
Like, that's a term that you're very supportive of. If I don't know, some people really don't like the term homosexual. Some people like the term gay. Some people prefer to have kind of the broad strokes queer. Would you feel comfortable with clinicians asking you about stuff like that, kind of starting off consultations, really laying the groundwork, understanding what terms you like?
Yeah, that's a very good question. I think it dictates a very personal answer. I think for me, Again, personally, I don't put too much weight on the wording of certain things.
Okay.
I think the intention behind that is much more important. And so if the clinician was to use a word that I didn't typically use in my day-to-day vocabulary, I'd be okay with that, as long as the intention, and I can recognize that the intention was sincere.
Sure.
But I do understand why people prefer to use certain words. And yes, in those cases, I would like for the clinician to ask that question first and establish that level of trust. But I also think it's important for the patient to share that information with the clinician as well. So whilst it's important for the clinician to establish trust with the patient, I also think it's important for the patient to do the same with the clinician. So, for example, if the patient feels comfortable sharing their pronouns, I think they should go ahead with that, and it helps the clinician feel a bit more comfortable, and opens that dialogue for further questions. And I think having that dialogue is important.
Yeah, you're right, it is important, because if you start to open that dialogue with clinicians, obviously we'd love it if clinicians were all very proactive in this respect and were like more considerate of people's pronouns, for example, or what terminology they like to use.
But it's also important to realise that that's quite a tall task. Given their workload already, it's just difficult in human nature, I believe.
Yeah, it is difficult, and you would hope that clinicians would be proactive in these circumstances. But if they're not, like Don says, if you come in and you introduce yourself and you share your pronouns, then maybe that clinician will kind of twig a little bit quicker that it's worth having a dialogue about what language you prefer to use. So I think it's a two-way street, isn't it? I think clinicians will only learn more once they are kind of, to an extent, taught by the patient how to have better clinical interactions. And hopefully if a clinician makes some mistakes with you, but they're learning as part of that process, hopefully that means the quality of care they provide in future will be of a higher standard.
Yeah, and I'd just like to reiterate or explain myself as to why I personally don't attach a lot of weight to the phrasing of certain things. As someone of a ethnic minority, it's kind of a double whammy. And so if I was to take offence at every little thing, I think I would drive myself insane. And so I personally think that it's easier to manage my life and the relationships that I've built with my loved ones and strangers if I look at their intentions instead of the wording, because that can open that dialogue, and then I feel more comfortable to have that dialogue with them, and then if I feel like addressing something, I do.
Yeah. You're very good at assertive communication.
Thank you.
But yeah, so I think that kind of brings a nice close to that section of the episode. When we were planning this episode, we thought about it was worth discussing the prevalence of pain in the LGBT plus community, discussing the research behind it, maybe the links between them, and how people in that community can be supported with their pain management. But actually we thought it was really important as well for any individuals who are transgender, for example, and they are in the process of considering hormone therapies or currently undergoing or considering surgery or have undergone surgery. Often the communication about that isn't particularly good quality and about some of the symptoms that you might experience. So we've gone diving into literature again about how hormones and surgery can impact people in terms of pain, what you might expect, what symptoms you might see, just so that you can know what to expect and know what's normal and what's not normal, so you can make sure that you have a kind of a good handle on what's okay to be feeling, either when you're on hormones or when you're having surgery.
Yeah, absolutely. I mean, there was an American study of 100 breast surgeries, of which 33 were breast reduction surgeries and 67 were transgender mastectomy surgeries. 75% of the transgender patients reported mild pain, and 4% reported severe pain. Whereas, in breast reduction, rates were 52% and 24% respectively. Interestingly, transgender patients use less opioids in recovery than reduction groups.
Yeah, and actually I think when you go looking about gender-affirming surgeries, it can be quite scary, particularly for transgender men who are undergoing mastectomy, because sort of the classic study that's used to describe this is of 92 transgender men who underwent this surgery, and over 27% of them developed post-surgical persistent pain.
Oh, that seems like quite a high proportion of people getting pain.
This is true. However, in studies of women with breast cancer, where they've also had mastectomy for treatment, the rate of persistent pain development was 28.2%. So very similar rates of persistent pain development. So sadly, both of those are still quite a high incidence of chronic pain after the surgery. But the good thing is that it doesn't seem like the outcomes for transgender men are any worse than for cis women in terms of having this surgery. So yes, it is something to consider in the surgery, but it's good to understand that the outcomes are relatively positive.
Yeah, so the risk factor for having the chronic pain is the surgery as opposed to demographics.
Exactly.
And can I just mansplain something, please?
Absolutely, please do.
And when we say transgender men, just to clarify for those of you who might not know, it means individuals who have undergone transformation from female to male. So just a little bit of education. Anyone who identifies as trans male has gone from female to male, and anyone who identifies as trans female, vice versa. Hope that clears any doubts up.
Thank you. I know that some people can feel lost in terminology, and I think sometimes...
And it's especially difficult to ask those questions sometimes.
True. I think people shut off as well.
Yeah.
Is that if you feel like something's too confusing, often you'll just kind of like switch off to it, and obviously that's not a healthy way to educate
ignorance.
yourself. It is called ignorance, but people do it, and it's better if we can provide some clarity.
Exactly, yeah.
And I think that harks back to what we were saying about medical professionals not being scared to ask those questions.
Absolutely.
Yeah.
And so that's kind of that's what the main literature speaks about with gender affirming surgery. From what we could see, there wasn't a great deal about chronic pelvic pain post gender reassignment surgery, was there?
No, there wasn't too much at all, in fact, Joe.
And it's hard to tell whether that's a gap in the literature or whether there is just low incidence of pain afterwards. Hopefully it's the latter, and that people aren't experiencing pain afterwards. But as and when more literature does come up about this, we're very open to the idea of trying to do a part 2 of this episode in the future when there's more literature that we can quote, because hopefully that's where the field is moving to invest more money into this important research.
So I think what we need to do now is, we've talked about the surgical aspects of chronic pain within particularly the trans community. How about the effects of hormones on chronic pain? So we can see that testosterone has been shown to be protective against pain in biological males, but it's uncertain if it reduces pain through hormone therapy.
So like for individuals who are trans men and they're having this hormone therapy, we don't quite know yet whether it has the same protective benefits. But what is really interesting is that this is completely anecdotal, but I worked in a rheumatology clinic during a placement, and one of the rheumatology physios was recounting to me a story of a friend of his who was having awful chronic pain, particularly like chronic pelvic pain, and she had a blood test and was found to have really low testosterone. So she'd been struggling for like 5 years, and she had really low testosterone. And after they gave her like a booster dose of testosterone, she was like, symptoms were gone in 2 weeks. So like obviously that's one case, but it does seem like there is something about hormones that plays a key regulatory role in our pain experience. So hopefully, fingers crossed, testosterone as a hormone therapy for trans men will reduce their pain, we hope. And just a little bit to throw the science in there, there's an inflammatory chemical called TNF-alpha, and it's thought that testosterone tones down the production of this inflammatory chemical, and that might be why it helps to protect against pain.
Ooh, well, you'd expect it to then show effects in people taking testosterone supplements, wouldn't you? Which is what you just mentioned in the rheumatology clinic. That's an interesting...
So reduced pain in individuals taking testosterone supplements as well?
Yeah, it'd be interesting to know if it presents like that.
I'd love to see some further data, but all of the data in this sort of thing is very recent, and there's still a lot to be published, isn't there?
Yes.
And I mean, we've talked about testosterone. How about estrogen? If testosterone is a pain reliever, effectively, is what we're trying to get at, what about estrogen? Is that then a pain killer, a pain inducer?
Well, it's funny, we don't really understand estrogen's role very well. Most of the research that we have about estrogen is from the menstrual cycle, but it does seem that at periods of the menstrual cycle where estrogen is at its highest, there does seem to be increased pain sensitivity to painful stimuli, so like heat pain or like
And like pricking and
exactly
physical pains, yeah. So nothing intrinsic, really.
yeah, not the chronic
Yeah.
pain, at least not that we know of, but
Also, is it estrogen or estrogen?
I always say estrogen. Estrogen's very American, but we'll turn to the doctor for a vote.
I say estrogen.
there you
Estrogen
go.
it is then.
I'm also northern, and if
Yeah.
you're from the south of England, maybe you'll pronounce it differently. I found that's a bit of learning for me.
Yeah.
I would have thought the northern was more like, oh, estrogen.
Estrogen.
Oh, estrogen. There is an O at the beginning. There's a hill I'll die on.
Wait, I've never seen it spelled without an O.
Yeah, the American spelling is
Really?
just
Yeah.
E. Same as
Oh.
esophagus and esophagus.
Ah, okay.
But I think obviously like that we spoke about how testosterone is potentially protective and estrogen potentially sensitizes a bit more. But we found quite an interesting stat, didn't we, Don, about female to male transgender individuals and pelvic pain after testosterone therapy.
Yes, so 72% of female to male transgender people developed pelvic pain after starting testosterone therapy, and 10% of these already had chronic pain.
No, sorry, it's 10% of them. The pelvic pain they developed became chronic. That was chronic.
Okay. So 72% of female to male transgender people developed pelvic pain after starting testosterone therapy.
Wow.
And 10% of these individuals had chronic pelvic pain after that.
Wow.
The pain was often described as cramping, aching, stabbing, or sharp pain. The pain was more common in individuals who experienced persistent menstruation or those who had current or previous episodes of PTSD.
That's really interesting, actually.
The PTSD?
Yeah, like again, we mentioned about this before, and like PTSD could potentially be linked with pain, but it's interesting that seems in this population to cause them to have higher pain scores.
Yeah. And then 72% of people with pain felt relief from NSAIDs or paracetamols.
And so, as we said before, NSAIDs like non-steroidal anti-inflammatory drugs, so things like ibuprofen and naproxen.
General painkillers.
Exactly. And then also, so 29.8% of male to female transgender individuals reported having painful conditions, and a quarter of this 29.8%, so somewhere around 7.5%, developed their chronic pain after hormone therapy. And then in female to male transgender individuals, 61.5% of them, so really high levels, reported having a chronic pain condition, but half of these conditions started to occur after hormone therapy as well. So I think really it's clear that our understanding of how these hormones work and the impacts they have on individuals is not very good, because there does seem to be sort of some people who are developing pain in response to this therapy. So clearly there's a lot more research to be needed about how we can deliver this hormone therapy that people need for like gender affirming treatments, but we need to make sure we can do it in a way that doesn't cause sort of challenging side effects, I guess.
Yeah, I think that's the theme of this episode, really. More research.
Yeah, I mean, I feel like that's just because historically it's been such a taboo subject, isn't it, to talk about LGBT plus health.
It's been pushed under the closet.
No, genuinely, it has. Yeah, traditionally, if back in the 70s, 60s, 50s, like how would you have got funding for this sort of research?
Oh yeah, it just wouldn't happen. Like it's hard enough now to get funding for any research, outside of kind of like the big hitters like cancer, diabetes, heart disease, for example. And so when you're looking in a population that makes up a smaller amount, like somewhere between estimates between about 5 and 20% of different populations, it's really challenging to get the research funding.
If we were to go back in time, I can only really think of LGBTQIA plus research being conducted when it came to a particular agenda, such as the AIDS crisis.
Yeah. Well, actually, I mean, there is quite a lot of link between incidents of HIV and AIDS and chronic pain. So if there is funding, sort of, being made available for AIDS research. Potentially this is an avenue where that research will go in future. And obviously that's a small proportion of the LGBT community, but, you know, considering how little research there is, all of it is super valuable.
Well, I think that takes us to the end of what we wanted to discuss today on our LGBT plus chronic pain segment, wasn't it?
Yeah. And we hope that we have been able to do justice to the research that already exists and to give you a clear picture of what it may be like and what experiences may be faced by LGBT individuals. And if you feel like there's anything we missed, please don't be afraid to write in. It's paininthepodcass@gmail.com. We would really love to hear about your experiences, about any advice that you've got for clinicians in order to sort of better manage these interactions, any interesting research that you think we've missed. Like, please do get in touch and let us know.
And that leads us nicely on to our book review this week. Joe, what book have we been reading this week?
We've been reading Why We Hurt by Frank Vertasick. It's a really, really nice book that delivers like a lovely mix between pain teaching, so sort of teaching about pain science, and genuine empathy and human compassion. And Frank Vertasick, I believe, is a medical doctor, and his way of looking at pain and how to manage it is a really, really sort of positive and forward-thinking way of doing it. So gave it an 8 out of 10.
Oh.
Which, you know, for a pain book is pretty high.
Yeah.
So thoroughly recommend the read. Well worth your time if you want to, especially if you're a clinician and you want to see how you could go about better managing your patients with pain. It's a really good place to go and learn more.
And for any youths listening, 8 out of 10 is usually an A tier, nearly an S tier. So there you go.
Leet. So from us here, we'd just like to say thank you for listening. So if you'd like to hear more, you can join us on Patreon, where you can listen to the breakdown, as well as seeing other content, such as us making fridge magnets.
That was very fun. We kind of tend to do a lot of creative stuff on there. So go check it out.
Yes, and until next time, take care. Garnier.
Because you're worth it.
TTFN.